Coming up next on Insights on PBS Hawaii, how can we better care for those who suffer from serious mental illness? Aloha and welcome to Insights on PBS Hawaii. I'm Daryl Huff from Hawaii News Now, your host for tonight's show. For those in Hawaii who suffer from serious mental illness, finding the right kind of help can be difficult and expensive. Hawaii has only one state-run psychiatric hospital and it's currently overcrowded. Even if you have health insurance, you aren't guaranteed treatment at private hospitals if no beds are available or if treatment isn't covered. What are the options for those who need psychiatric care? Tonight on Insights, how can we better care for those who suffer from serious mental illness? We would like to hear from you during tonight's conversation. Call 973-1000 if you live on Oahu or 800-238-4847 if you're calling from a neighbor island. You can watch Insights streamed live at pbshawaii.org. Just click on the title of tonight's show, or you can find us on Twitter at PBS Hawaii. Now to our panel. Dr. James Westphal is the Chief of Psychiatry for the Adult Mental Health Division at the State Department of Health. The division oversees Hawaii's only state-run psychiatric hospital, the Hawaii State Hospital in Kaneohe. Dr. Barry Carlton is the Chief of Psychiatry at the Queens Medical Center. The Queens Medical Center is a private hospital which offers both inpatient and outpatient psychiatric care. Melinda Dallas has personal experience navigating the options for diagnosis and treatment of mental illness in Hawaii. Her sister suffers from bipolar disorder, has been arrested several times, and has been in and out of the Hawaii State Hospital. And Dr. Jeffrey Akaka is the former president of the Hawaii Psychiatric Medical Association and currently its co-legislative representative. He's also the medical director for Diamond Head Community Health Center. Let's start with you, Melinda Dallas. Please tell us your story of your sister and how has it been?
It's a long story. She has been struggling with mental illness since she was 17 or 18 years old. We always kind of knew that there was something there. It was never diagnosed until about 6 years ago. She had her first psychotic break at school. She was going to KCC, and she, had an episode where she started hearing voices, and she was threatening her classmates, and it was scary. And so they called me. I was the closest family member, so I went to go get her. I just took her to my house, and I tried to calm her down. And from there, it's been kind of just this downward spiral of just, she's not only is she mentally ill, but she uses illegal drugs. And she's been in and out of Queens a lot of times. She's been in the state hospital one time for 6 months. She's seen several psychiatrists, but trying to get her help, it's just been so difficult.
What's the main barrier, would you say?
Well, one, there's no options for her. During the most recent time, probably the hardest time, she was pregnant. The last time, actually she was just recently in Queens, but the last time that I saw her in Queens, she was 8 months pregnant.
How long ago was that?
That would be 4 months ago.
So do you know whether she's had the baby? Or?
I do. I actually have her baby.
Wow.
Yeah. But the whole thing was, she'd go into Queens and then they would tell me, well, you can send her to Women's Way. But Women's Way was the only place that would take somebody who was pregnant and using drugs and mentally ill. And she couldn't get in there because she had to interview.
Let me just take the conversation over. Dr. Akaka, how typical is the experience that Melissa is describing?
Well, everybody is an individual, and each situation requires looking at, well, what does this person thrive on? What do they need? What are they willing to do in order to get what they want? And if you can frame whatever it is that they need closest to what they want, then you have a better chance of success.
But in terms of that, who are there available resources to put on someone who's in this kind of condition?
There are. unfortunately for you, it sounds like the family is the resource that's being taxed most heavily, and that's often the case with most situations.
Actually, I don't agree necessarily. There are resources, that is true. There are very limited to no resources for people without insight. And I'm not going to comment on the story as been told, but if somebody does not have insight and doesn't wish to change, which is a large problem with the co-occurring illnesses, access to any of either the co-occurring drug treatment programs or the outpatient programs is almost impossible.
No, just so I can, just to rephrase this for the benefit of our audience, when you talk about co-occurring, we're talking about people who have, say, both substance abuse and mental illness. Is that correct?
That, and actually at this point also medical illnesses. The ravages of methamphetamine have created people with psychiatric illness, very damaged hearts, and substance use.
And then when you talk about lack of insight, what does that mean?
Especially for for either residential programs for co-occurring psychiatric illness and substance use, or any outpatient programs, the patient for a physician, client for everybody else, has to accept that they're ill, that they need change, and that their symptoms are caused by an illness, which for people in the midst of acute psychiatric illness or intoxication from substances is very difficult, if not impossible, because of what the substances, as well as the illness, do to the brain in terms of reasoning or lack of, as the case may be.
So let me take this to Dr. Westphal with the State Health Department. How widespread is this sort of psychiatric situation that the doctor describes? Are there lots of people in Hawaii like that, lacking insight, multiple diagnoses?
Yes. Short answer. In the state hospital, 92% of the patients there, when we last did a look, had a co-occurring substance use disorder. So more than 9 out of 10 people at the state hospital have both a psychiatric disorder and a substance use disorder. In addition, when we last looked at medical illnesses, about 1/3 of them had serious co-occurring medical illness, heart disease, diabetes, hypertension.
Let me ask this, though, do all of these people need to be in a state hospital or in a long-term psychiatric facility? You only have about 200 beds at the state hospital, another 40 beds at Kahi'imohala. Are there many, many more people that need that treatment that just can't get it simply because there are no beds?
That's a really good question. Let me just parse it out a little bit. Sure. So the state hospital ideally is set up as a hospital to care for people that have acute psychiatric problems and or acute medical or substance use disorder. However, we're also a place of custody. So someone who has been adequately treated, is taking their medication, may stay there and not needing acute psychiatric inpatient care, may stay at the hospital for years to decades because they're considered that they would be dangerous if they were released from the hospital.
So you're basically warehousing these people?
Well, yes, not warehousing, because warehousing would just mean that we're just putting people away and keeping them away. But it's a court.
Babysitting? Is that a better word?
Babysitting. Yeah, well,
I don't mean
under
to be
custody. Yeah,
patronizing
but some legal court has designated that they have to be at the hospital.
Melinda, I called you Melissa.
That's okay.
How does it make you feel to hear that there's people who don't need to be in the state hospital who are there while your sister is out in the streets, basically?
Well, I mean, she was in the state hospital at one point, and it did help her to have a long period of time where she was being treated for something. But I think what is more difficult for me is people use language like lacking insight. Lacking insight would indicate that she that it wasn't her disease making the decision. She she would ask for help, but then, you know, at some points she is telling me that, you know, oh, the military's watching her and she can't talk about, you know, what they told her to do. And she thinks in her head that they're telling her to go and use crystal meth as an experiment. She told me that just a couple weeks ago. You know, so I mean, it's, when you say lacking insight, where is the line that we are drawing to get people the help that they need that they might not be able to ask for?
Lacking insight to me is the disease. It's not.
Yeah.
It's not willful. So I mean, that's the disease. Unfortunately, the way our laws are structured, obtaining help for people who would be considered gravely disabled but not imminently dangerous is inordinately difficult.
You know, yeah, we are going to. I want to explore that in some detail a little bit later because let me get. I just want to make sure we have a sort of a baseline understanding of the resource that's out there. And as you were saying, Doctor, you feel that there's a real shortage of resources. Where is the real gap?
It depends upon the illness and the age group. So, for example, for the elderly, and we have the highest percentage of the old in the country gradually. So for the elderly, facilities, supportive facilities, not necessarily hospital, that can help manage dementia safely with the co-occurring medical illnesses is awfully important because it's outside of the ability of families or of open places to save because the elderly wander. For the younger person with co-occurring substance, psychiatric illness, there are hospital facilities. However, they're limited. Hospitalization, by its very nature, is for acute care. And again, under our laws, if someone is not suicidal or a threat to another, and they are very ill but wish to leave, they can. Housing, the statistics on successful treatment of psychiatric illness, going back to the Robert Wood Johnson grants of the late 90s, or correction, late 80s, early 90s, all housing. The successful grants in Philadelphia and in Columbus, Ohio, and a few others demonstrated the importance of housing.
Let me move to Dr. Westphal. So when did we start falling behind in terms of the resources that were available? And was it, we often hear about a time in the 70s and 80s when deinstitutionalization became so important. Is that what our problem is, that they so de-emphasized institutions that the institutions kind of withered?
Okay, so it's a two-part problem.
Okay.
And so we don't have enough inpatient psychiatric beds. We probably haven't had enough. Many states still have the ability to do what's called a civil commitment to a state hospital for several months, not like a couple of days, not limited to if you're just suicidal or violent, and to do more long-term adjustment of medications, more long-term sort of analysis of the problem and trying to find the right therapy and the right combination of medications. As Jeff said, everyone's an individual and you really have to work to find what's going to work for a person. So we don't have inpatient beds.
How large of a shortage would you say there is, though, of those?
I calculated this, okay. So we're about 200 beds short. And it's going to take us 8 years to build them. So we're still going to be short beds.
Didn't the legislature just approve money?
Yes. And it's going to take 8 years, at least according to the current plan, to build those beds. So we will be, probably short for a while. But we do need those beds.
Well, why do it take 8 years?
You have to talk to our architects about that. I mean, that's the plan. All right. I'm not an architect, but that's what was reported to me. We've got an 8-year.
So 200 beds short for quite some time.
Yes.
What about community beds?
Okay, so community beds, that's a different story. Okay, so we were relatively adequate. But with the recession of 2009, there was a tremendous cut now in community resources. And in housing, case management, a lot of things got cut. In the last several years, we've been restoring that. We're not quite at the level that would put us back to 2009, but we're getting there. We're at 75, 80% capacity. And then let me just finish one more point. So there's a particular type of bed that we lack. We need a locked unit that's not hospital level care, but can contain people that wander, that might, that would wander, or that need confinement, and what I would call residential care.
I'd say protection rather than confinement.
Okay, protection. Okay, protection, thank you. Protection of themselves, protections of others. And sometimes it takes, especially with methamphetamine, it takes months and months and months for those symptoms to go away.
Okay, let me just move to Dr. Saka for a moment. Doctor, where do you see the gaps in the system?
It's real hard to provide care. I mean, as a psychiatrist, and we don't have enough psychiatrists. Frankly, we don't have enough physicians, period. We don't have enough family physicians. A lot of physicians are retiring earlier, much earlier than they used to. Docs used to work until they were in their 70s, 75, 80, but now they're leaving at 60 and 55 because it's so hard to feel good about spending more than half your time doing paperwork and fighting with managed care companies that have the money and won't pay you after you've done all of your work because you didn't dot an I or cross a T.
Is psychiatry any more difficult than some of the other fields of medicine in that regard?
I don't believe so.
Not really.
I think all specialties. Yeah.
There is a shift away from private practice into either government or institutional practice in many fields.
Yeah, the private docs used to take care of a lot of people who were very, very ill. You know, people like your sister. A private doc used to be able to take care of that, a private psychiatrist.
How would that work?
But
with someone who's as ill as Melinda's sister?
When someone is stable, like the people I take care of, I mean, we do have a team where I work, and so there's a lot of support from social workers, psychologists, nurses, who do a lot of hand-holding for people who are severely ill. But if someone has been with a psychiatrist for many years and a level of trust builds up, you don't need as much of that hand-holding that you need initially to the point where a person gets very comfortable with you. Almost like becoming a part of your family.
So, but we are talking about another shortage category then also. I mean, so what it sounds like you're saying is if there were more psychiatrists available, you would be able to maintain more people in the community and maybe not have as high a need for the psychiatric beds?
That's true.
If I didn't have to take care of as much paperwork, I could see twice as many people as I'm seeing now.
Oh, I see.
That's true. There are also, Dr. Westphal mentioned the withdrawal of services. The hours of case management services that is available for a patient is extremely limited, and it's not, as the way I understand it, incredibly flexible. So, for example, when someone is acutely ill for whatever reason, be it methamphetamine use, mania, schizophrenia, they may require monthly 15, 18 hours of case management services.
What does case management mean?
I'll explain that in a minute.
Okay.
To help keep them in the community. This is a non-medical professional whom establishes rapport with the patient and attachment and can get them to appointments because they have rapport and attachment, can make sure that they go to a day program by picking them up or bringing them back and forth, so to speak, so that they can have safety for 6, 8, 10 hours. They can offer, in some ways, relief for the families when that occurs.
Melinda Dallas, have there been periods of time when your sister had a good relationship with a provider and was able to be like that?
Caseworkers, yes, and she's had a couple who she really likes, but they are stretched really thin, you know. I mean, then And not only that, but they're not always able to get in contact with her. You know, in the times when she's extremely ill and she decides that she's going to go live out on the streets. I mean, how do they help her? You know, I mean, I know too. I mean, they have. I would say that the ones that I've met have been very helpful as much as they could, but there's such a limit to what they can do.
Is that something you ended up having to do, is hunt around for doctors, hunt around for police workers?
And actually, we mentioned Kahi'imohala earlier. I called them because I had taken her there a couple times before when it first started 6 years ago. Well, I called them recently for a place to take her out from Queens because she was getting ready to be discharged, and they told me that they closed their adult program. They no longer have a dual diagnosis program.
Well, Doctor, sorry.
That's true. They changed the configuration of their beds, and I'm not employed by Kahi, but I'm not sure of the numbers. They still have a robust child and adolescent program.
Right.
They do have
That's what they told me.
state
They only
hospital beds, and they have a trauma unit for the military, but they no longer have, as far as I know, acute psychiatric beds
You're talking
for
about
adults.
Kahi'imohala.
Yes.
And you go, Dr.
I'm going to jump right into
Yeah,
that.
go ahead.
So one of the reasons the state hospital beds are stressed is that, as we've just said, the private psychiatric beds across the state have shrunk in terms of numbers over the last 2 decades.
Except Queens, ours have expanded.
But in total,
They're down.
they're down. Okay, so oftentimes those beds could handle people with emergencies and that sort of thing. So Hawaii is unique in 2 ways. And these are national trends. Okay, we have criminalized mental illness to a greater extent than almost every other state in the United States. So the proportion of people in psychiatric beds with criminal charges is very high. It's in the 90s.
At state hospital.
Yes.
However, in the jails and prisons, you're still running, I think, about 30 to 40%.
Right. Okay.
Serious and persistent mental illness.
Right. So what I was going to say, though, is that is not true in other states, that the state hospitals do not have predominantly forensic patients. They're increasing, but not to the levels we see here. The other issue is that our state hospital beds are much greater in proportion to the private psychiatric beds than other states. I mean, the only state that has greater percentage of state hospital beds is Mississippi. Okay, so I mean, more care is happening in the state hospital there than any other state in the country, and we're like second or third.
This is a question from our viewers. They're starting to come in now. Comment: as a case manager, I see clients which are the most severely mentally ill who cannot get into the state hospital unless they're arrested for committing a crime. Mm-hmm. The police are letting them go for crimes, thinking they are doing them a favor. The police are letting them go, I think releasing them, even though they've committed a crime, thinking they're doing them a favor, but because there's no resources. First, Melinda, has that been your experience?
Oh, yeah. Yeah.
Tell me what happens in a case like that.
Because actually, it's a pretty clear difference because 6 years ago, when this first happened, Crystal got arrested for a trespassing charge. She went to the state hospital. They kept her for, I think, 6 or 7 months and were really able to kind of help her get treated. She went out, she got into an outpatient program. That was the best that I've seen her do. Now she's been arrested 4 times and they've just keep letting her go. And she'll go to court and they'll give her 7 hours of community service.
So she'll go in and she'll plead guilty to the crime,
yeah.
And because the defense attorneys believe that they're better off pleading guilty, getting something on their record, but then they get released as opposed to getting sent to the hospital.
Right. Or she never goes to her
I
court
think that's
dates.
more of a symptom of a sick system. I'm not convinced that that's the right way to go. So, for example, the police, as well as most providers or professionals, if someone is gravely disabled but not dangerous and doesn't wish treatment, there's almost nothing that can be done about it. Whereas in other states, that isn't true. Grave disability in other states is a reason for involuntary hospitalization if it's indicated. Other states have a conservatorship system so that if somebody is involuntarily hospitalized and requires medication management or safety or even medical illnesses, they can access it. We have, I'm not really expert in this, and Dr. Akaka probably is better than I. We have what amounts to a kind of a rudimentary outpatient commitment law that is, the last time I checked, incredibly cumbersome, and I don't think it's been used successfully more than once or twice.
Yeah, let me I'll get to that because I do want to cover that subject. But Dr. Westphal, just to repeat what you're saying, what proportion of your resources are taken up because the courts have sent you someone and you've treated them and maybe they're ready to go, but they're stuck? Mm-hmm. Can you give me a sense of that? And is it possible to get in the state hospital, like this caller is saying, without being charged with a crime?
No, it's not.
No, it's not, okay? And
That's an incredible statement.
I
right?
understand that. I understand that, and we're somewhat unique. However, I read a report from the year 2000 that said this very same thing, and it was a report to the Hawaii State Legislature that said Hawaii is the only state where you can't do civil commitments, and there's a tremendous problem with that. Okay.
Yeah. Okay. So, Dr. Kaka, give us an update on where we are. I know you've been involved with the legislature some. I mean, my understanding at Hawaii News Now, we just did a story about this last week, and there have been several attempts to use the new law that have yet to succeed with 3 different judges, and other sorts of available tools, for example, guardianship by the courts, are also not heavily used. Can you give me a sense of what tools are there for someone who's clearly in need but not able to check themselves in or try and check themselves in?
Somebody who's in need but not able to check themselves.
Just lacks insight, is just out on the, let's use an example of someone who's out in the streets and just is not capable of walking into the doctor's office and getting themselves committed.
Yeah, that's a really tough situation. There is health care for the homeless, at least in the Waikiki area. The crisis,
of course, we've chased them all out of Waikiki.
Well, but some continue to go there for their health care and some mental health care there. The homeless shelter also is beginning to provide psychiatric care for people who are in the homeless shelter, down in Iwilei. So those are some resources.
IHS?
Yeah.
My sister was there. I don't know if she got any. Just recently, she just left about 3 weeks ago. I think she decided she wasn't going to stay there anymore. Right before this last time she was in Queens.
Okay, we'll pursue this a little bit more. I want to once again remind our viewers that tonight we're talking about how to better help those who suffer from serious mental illness. Please call, email, or text your questions and comments. Call 973-1000 if you're on Oahu, and 800-238-4847 if you're on a neighbor island.
Go back to the guardianship issue because it is important.
Certainly, I want to
for families who are trying to obtain guardianship. Emergency guardianship can only be obtained, as I understand it, if there's imminent danger. The Office of the Public Guardian, if the families can't afford legal representation, is at least a 6 to 9 months wait. And in the private sector, I have a patient now whose family is going through the private sector. The delay in court time, I guess from the start of the proceeding to the hearing, is at this point 6 weeks to get on the docket. So
that's
no one's bad there. I mean, I'm not suggesting no one's bad there. It's just that it's very overcrowded.
But this is for what kind of a situation?
That's for guardianship, for psychiatric illness where the patient is unable to care for themselves in a variety of ways, but is not imminently dangerous.
So Dr. Westphal, how does that system work in relationship to the state?
It doesn't. A guardian cannot sign a patient into the hospital.
Right.
Really?
Yes.
So you could go through. So that's the flaw there.
It doesn't. Yes.
Right. Well, but let me. Okay. So let me just talk about an assumption here. Hospitalization is not the best care It's the most intensive care. It's the care that confines the person the most. And in a situation where they need confinement, it's what's needed.
Protection.
Yeah, protection. Okay, or they need protection. That's the best situation. But really good psychiatric care can be done on an outpatient basis.
Yes, but if we don't provide services in the community and we don't provide access, we then overuse acute care.
I agree.
And then the total cost of care is too high. And the other problem that we have, which is not just Hawaii, it's national, that the total cost of care isn't owned by anyone. So the hospital piece, which is pricey, is paid for by the insurers generally, the different plans. However, they don't, and the outpatient is paid for by the insurer or the plans, but they don't connect in terms of the total cost of care of the patient. So you wind up with episodic care.
We'll get to financing in a minute. I've got a question I want to come to, but Dr. Akaka, just to get back, what is it in Hawaii that you see that causes us not to be able to cross the bridge that other states have crossed in order to get civil commitment?
I think that's,
I guess what I'm getting at is, what is the argument that's being used to prevent us from having a different or stronger law on that?
well, as far as why is it harder to get a civil commitment? I think,
in terms of why is the law, you've been at the legislature trying to get better laws for the mental health, and I'm just wondering, what's the argument? Does someone come in and say, oh, it's a bad idea to get a better civil commitment law?
it always comes down to the person's individual rights as opposed to a community wish to help somebody out. There's a multi-decade old decision that you cannot force somebody to get treatment. Patients have the right to refuse treatment.
Is that unique to Hawaii?
No, that's national.
Okay.
That's pretty much a national standard. So as much as a family member,
If they have
even,
capacity.
Yeah, exactly.
Yeah.
So
Yeah.
even without
Yes.
capacity
Yes.
in Hawaii, though,
yeah, but you
get
get the 9-month wait list to establish that.
I understand that.
Yeah.
I said I would not be contentious.
Oh,
okay,
so
go ahead,
let me
yes.
I want to jump in on this one. So it's really the disease that's very important, but the assumption of the law is if you're an adult and you're 21, you've got capacity. And what the law hasn't caught up with is that these diseases really make it almost neurologically impossible for people to have true insight or make really good decisions about whether to be in treatment or not. So there's a conflict there in terms of what the law sort of envisions individuals as being rational and choosing their individual rights versus a disease where that's really not happening at all.
If I could say something, it's really important to understand that capacity, the legal determinant, if somebody's capable of making decisions, that's not the doctor's call. It's a judge's call. So a doctor might say, look, this person really needs help, they don't know what they're doing. But unless a judge can be convinced of that, then the doc's way may or may not be held up in court.
Have you gone through this, Melinda, with your sister? I mean, okay, so tell me a little bit about that effort.
Well, actually, I tried to find out about a guardianship, and I pretty much got an answer from both people that I spoke to at Queens, as well as an attorney that I spoke to, that even if I acquired the guardianship, I still was basically not going to be able to make any decisions for her. I wasn't going to be able to get her the help that she needed, which at the time, I was really, let's just say, for example, in Florida, you can petition a judge. You and 2 other family members or 3 independent parties can petition a judge to say this person is exhibiting dangerous behavior. No, they're not going to, it's not imminent danger, but they're severely disabled in taking care of themselves, making decisions, exhibiting dangerous behavior, and you can have them committed for up to 90 days. And they can get
with
treatment.
active treatment.
With active treatment, right.
Our law is separate. So in this state, the commitment law will, if they meet the criteria for involuntary hospitalization, will get them into the hospital, but it will not define treatment. The two processes
Right.
are separate.
Right.
And it is my understanding that the grave disability or obviously ill part of Section 334 was declared unconstitutional by Judge Ezra a generation ago and has never been rewritten.
Okay, let's talk about money for a little while. We've gotten two callers asking kind of a similar question. Is some of the homelessness of the mentally ill a result of President Reagan closing mental facilities and hospitals? And another one, and this is about federal funding, obviously. Until 2009, the ACT program in Hawaii was very successful, improving quality of life for many. Program was terminated by Governor Lingle. It was expensive but effective. What do you folks think about this? Is it fair to blame the Republicans? You were there, Dr. Westphal. What do you think?
Well, okay, so I was actually training in California during the Reagan deinstitutionalization period, and I've actually worked in several systems. Like when I was working in Louisiana, they had a state hospital that had 32,000 patients, consumers.
32,000 in
32,000 patients
in a hospital.
In hospital before institutionalization, and it was their own community. They had farms. They had they made dairy farms. They grew their own food. It was basically a town that and an economy that ran with the consumers having things that they could do. Okay. And at the state hospital here, I don't know the exact numbers, but before deinstitutionalization, wasn't it like 15,000 people were there?
I don't know the answer to that. I don't think it was that high.
It was much higher.
It was much higher. I thought it was about 2,000.
2,000.
From at least the settlement agreement when the institutionalization began, it was
So the 70s.
about 2,000, 2,200.
Okay, but the point is, and they were very stable, and people weren't pushing them out the door. And so there were places for people. Many people got displaced. There's like one of the things that we really learned in my residency is there's two things you can do to treat mental illness. You can give them medications and somatic treatments, and structure. And structure like housing and that. So you go from very highly structured environments to very low structured environments. Like see a case manager a couple times a week. It's very difficult for a lot of people to function with that level of structure.
I think the deinstitutionalization movement in and of itself did not really create the problem. Large state hospitals that where patients were not treated. In ours, for example, you could have been a patient at state hospital prior to the settlement agreement, and you wouldn't see a doctor from 1 year to the next.
Describe a little bit about the settlement agreement. I don't know if everyone remembers that.
The state was sued for the conditions at the Hawaii State Hospital that didn't provide adequate treatment for people who were involuntarily committed under a federal statute. So deinstitutionalization itself was not a problem. What still remains a problem here, and this is hard, is housing. That is, and that was the book was Madness on the Streets, which described that. Very good book. But here we've never been able to get a hold of the housing piece. And housing is so valuable for many people that contingency management, if you do this, you keep your housing, is very important. And we've not been able to do that. Nobody is bad with that. I'm not suggesting there was an evil intent, although for the consumers and their families it feels that way. But nobody was really bad. But the housing piece is incredibly important.
Let me move on also to talk a little bit more about financing. There's a couple of questions here. This one caller says that publicly supported medical care, such as Medicaid, et cetera, is it a fact that so many are on Medicaid, et cetera, a factor affecting the lack of psychiatrists? This one says in Kona, but that could be everywhere. Dr. Akaka, the low reimbursements from government health programs, how big a detriment is that to the psychiatric profession and the ability to keep it robust?
Huge. Yeah.
Especially on the neighbor islands.
Yeah, you can't make a living as a private psychiatrist on a neighbor island.
Why neighbor island why is it different than neighbor islands in Oahu?
This is, you could consider this hearsay, but from what I hear, so much of the neighbor island populations are on Medicaid or Quest, and the reimbursement rates are so low, and often people have trouble getting to their appointments. You don't have public transportation like you got, on Oahu, so you just can't get enough reimbursement to keep your office open.
Dr. Carlton, how much impact does that have on an institution like Queens, where you get the most emergency inpatients, people right off the street coming in on a regular basis?
Actually, all of our assessments are done needs blind, and are done insurance blind, so we have no idea. It is true that the medical center loses money on every psychiatric admission in terms of reimbursement.
So even with the economies of scale associated with a big institution, you're losing money.
You're losing money.
Let alone the poor private psychiatrist, right?
And although the mission at Queens would be to take care of the people the best that way we can, and actually psychiatry has been at Queens since its founding by the founders.
Here's an interesting question, and probably one of our private docs, it'd be best to bite on this one. I have a sister who's mentally ill as a result of an accident at work, and so she's relying on workers' comp for her coverage. I understand the workers' comp system in Hawaii is particularly stingy and difficult to deal with. Dr. Akaka, is that your experience?
But I don't have that much expertise with it. In my clinic, we don't.
Oh, that's right. You guys are
patients on workers' comp. Yeah.
Dr. Carlson?
It's difficult. I mean, however, one would wonder about access through the Medicare, Medicaid system, or the Quest plans. Workman's compensation itself for psychiatric illness is a very cumbersome system.
Is it cumbersome and also less generous, or is it just cumbersome?
Generous, not particularly generous.
One of the biggest difficulties for doctors trying to take care of people is that there are so many different funding streams that have so many different sets of rules accompanying each one that it's impossible to keep up with all of them unless you hire extra staff who are experts in maybe 4 or 5 of the different plans. We didn't have this problem 20 years ago. You pretty much, you saw somebody, you gave them a bill, and you got paid. Now you have to kind of figure out, well, are they going to pay for this? Are they going to pay for that? Are they going to pay for a certain medication if the patient belongs to their plan? Or do I have to change the medication because that plan will pay for medication X, but they won't pay for medication Y?
Okay. Let me try another one. This is we'll start trying to get hopeful later in the show. Right now we're not doing too well. If none of the doctors in my plan are taking new patients, what can I do?
That's an insurance company problem by definition. And we have a problem here too with access to physicians within a timely fashion after hospitalization, and that clearly, if someone has a plan, be it Ohana WellCare, be it Quest HMSA, be it Aloha Care, the plan is obligated to find the provider.
Right. And
yeah, let me jump in on
sure.
this one.
Okay.
Yeah, in 2008, Congress passed the Mental Health and Addiction Equity Act, which mandated, it's a law, that insurance companies, if they cover psychiatric care, have to put
Which
no
in this
more.
state they have to. Under the Prepaid Health Act, they must.
Yeah. They cannot treat someone who's getting their psychiatric care any differently than from any other medical illness, like diabetes, heart disease, whatever. And the American Psychiatric Association, which I belong to, put out this poster to help people who are exactly in the situation you describe, where if your plan does not have a doctor on their panel, it's that insurance company's job to find a doctor for that patient.
Even if the doctor's not contracted with the plan?
They have to find someone.
So
It's a plan's obligation.
It's a legal requirement.
are the plans meeting that obligation in Hawaii?
From where I sit in terms of my information, not always. But again, I can't answer that with numbers. I can only answer it with examples.
Sure, I understand. Another question, and we're kind of circling back to another issue. The Star Advertiser did an excellent story the other day about the amount of police contact with people with mental illness, and came up with the astounding number from the police department that 51% of their arrests
Huge.
were people with mental illness. Melinda, tell me a little bit about the experiences of your sister with law enforcement. Any idea how many times she's been arrested now?
In Hawaii? I shouldn't laugh at that, but 6 or 7.
You gotta laugh sometimes.
Yeah, you're gonna get a laugh or cry, you know, but probably 6 or 7.
And then, has she experienced, I think you did mention that she's experienced where police will not arrest her or they'll take her to the hospital.
Yep.
What happens when she goes to the hospital under those circumstances?
And then she's usually discharged, I think the longest she's been there is about 5 or 6 days, but usually she's out within 2.
And do you think that she's out before she should be out? And I'm wondering whether that's because she says, I want to go, or because...
Well, I know, yeah, and they can only, I mean, it's really more, it's more of a problem with the law and what they can do, because they can only hold her for, what is it?
It's 48 hours to assess for dangerousness. If there's no evidence of dangerousness, even if they are very ill, patient has to be released.
The thing that what strikes me about that number is that it's an indication of the kind of resources, the shifting of resources that happens, right? Because we don't have resources in the mental health system, it ends up being a burden on the police, and so on and so on. Is our system still underfunded from the government point of view? We've talked a little bit about private insurance, but I mean, from the government point of view, let me start with you, Dr. Kaka. Do you feel like we're still vastly underfunded? Is that the biggest issue?
We spend more money on healthcare in this country than any other country I know. I mean, it's not a matter of being underfunded. It's a matter of not being efficient. There's huge amounts of money that are being wasted. You're
not advocating for a single-payer system, or are you?
Well, there are a lot of merits to having a simpler system where the doctor can spend more time taking care of the patient instead of the paper.
Mm-hmm.
But in terms of the government resources, let me ask Dr. Westphal. I mean, we talked earlier about being promised a building that's going to take 8 years. I'm sure that 8 years has a lot more to do with, I mean, if you put enough money in it, you could probably do it faster than 8 years. Wouldn't that be your guess?
I think you could do it privately faster than that.
But how do you feel about the funding levels of your division, for example? Do you go to the legislature and get everything you want?
We try. Well, let me just say, historically, we've had, like I said, we had the problem that we needed more beds in 2000, and it's taken to the point now where we really have a crisis.
We're 15 years later, and we're talking about 8 more years before we get this
so it's
23-year
gap. So that's an issue. But we've got to take this, put it in context. These types of issues are occurring all over. The 3 largest psychiatric institutions, if you just talk about the population of mentally ill, are Rikers Island Prison, Cook County Prison, and or jails. It's the jails.
And OCCC here.
But Los Angeles, their jail, they have enormous amounts of mentally ill people. Okay, so care has been shifted from medical settings to more forensic, criminal justice settings, and that's not just Hawaii. And 51% sounds about right from that article.
But let me get back to my original question, though. You very diplomatically avoided it. I mean, how underfunded do you feel like the state piece is here?
I'll answer for him because it's a trap question.
Yes.
Because you have resources not being well utilized. So in the total aggregate, there is money in the system. Now, I don't know any longer, I did once, how many patients are at HSH that clinically don't need to be there, but are forensically whatever. I'm assuming you're at about $1,000 a day of expenses.
Yes.
So if it's licensed beds are currently 164.
Well, that's the licensed beds are 202.
202. And how many are you utilizing?
We're at 200 today.
So if you're utilizing 200, and let's say even 70%,
I think the number
even
is
30% don't need to be there.
Okay.
And so that's 30% of 200 is 30 beds.
So that's you're really pointing the finger at
It's poor
a number
utilization.
of places, but how do you fix poor utilization? So we've heard that the court system is keeping people in who don't need to be in. We're hearing at the same time it's impossible to get someone in who needs to be in without having them arrested. I'm getting a couple of callers who are expressing exactly the same frustration Belinda has, is that they've got family members out there who are homeless, not taking their meds, and he's on the streets. How can I help him, says Tim. And here's another one. Her sister's been arrested and released. She refuses to take meds. What can the family do when they do not have guardianship? Or if they have guardianship, I mean, should you literally call the police and say, go arrest my family member?
You can try.
You can try, but it won't be successful.
Why not?
If there's no danger or no law violation.
It was actually suggested to me by somebody involved in my sister's case along the lines that I should actually go to the police and make a report that she had attempted to hurt me.
Make something up.
Yeah, in order to get her into the state hospital.
Okay, so we've talked about the need for improving our laws on civil commitment. We've talked about what is the issue about why is it that people are stuck with these court orders for a longer time than they need? Where's the disconnect there? Is it getting back to court to get them released, or what's?
No, it's okay. So there's different types of legal commitments to the hospital. If a person pre-trial, they're high on meth and they do something and they get arrested and they're hallucinating and not making sense in court, they're unfit to proceed in their court proceedings. They go to the hospital, usually for a more briefer stay, okay? And hopefully, they stop taking medications, they start eating food, they start getting hydrated, they take some medications, and they get their capacity to make decisions back. Then
that's one type.
That's one type of, and that's relatively short.
Is that a very large group?
It's the second largest admission group in terms of all the admissions in a year. It's the second largest. It's around maybe 60 to 70 patients a year.
Okay.
So but you're talking about 200 beds. That's a nice chunk. Okay.
Right. And then the second biggest group.
And then the other group is people who've committed a crime. It can be a park violation, that they were sleeping in the park. It could be someone took a sandwich, because they were hungry, or it could be attempted murder, and they're committed to the hospital, and they cannot be released until they go through an evaluation process. Independent doctors, 3 of them, have to look at a person's dangerousness. Okay, so it's like an indeterminate sentence. You could be there for your whole life if the
3 doctors can't agree.
You can't agree that you're not dangerous. Okay, so many of those people take their meds, are stable, but say they've done a particularly publicized crime or something like that,
They're never going to get out.
they're there, and they don't need hospital services. So I agree with what Barry was saying, that I don't know how much total money we need, but the money we have could be spent more effectively.
Okay.
I want to actually make a different point, because I'm a little bit concerned.
Got about 1 minute, but go ahead.
Oh, I'm concerned about the nihilistic view of all of this. There have been really enormous advances in psychiatric illness, in medicine management, in pharmacogenomics, checking how a patient metabolizes medicine to understand treatment failures better. There have been whole chunks of new treatments for depression, for refractory illnesses that are offering people benefit. So we have focused on a particular problem, which is quite real, but I would hate everybody to leave with the idea that it's futile.
That it's hopeless.
Because there is a large amount of significant improvement that physicians, psychologists, others, there are evidence-based psychotherapies that are helping people. There are refinements in medicines that are helping people. And so it is not as bleak as this conversation
I have
has
to
been.
I have to stop. We'll come back with an internet section, but first I've got to say thanks very much. And on next week's show, more visitors are coming to Hawaii, but few hotels are adding rooms. According to hospitality advisors, many visitors are staying in legal and illegal bed and breakfast, timeshares, and other alternative types of lodging. What does this shift mean for tourism-related jobs? How are changing visitor preferences affecting Hawaii's tourism industry? That's next time on Insights on PBS Hawaii. I'm Daryl Huff from Hawaii News Now. Ahui ho.